Thanks, guys. So this is going to be a little bit of a different talk. Everything you've been seeing has been pretty traditional and pretty basic. Even though it's been 10 years, I consider Gordon's concepts now traditional, and it's something that I think is now common practice, honestly. I'm going to talk about stuff that's really not common practice, and it's more kind of where I think we're going in the future. So my disclosures. And the internal brace for cuff repair is still not quite a thing, still not quite there, still being worked on, still being conceptualized, fine-tuned. So I can't say that in all honesty that I can present to you a concept that is now solid, ready to go. I still think there's some more to come. What I can tell you though is that I've been actually talking about SCR now for over 10 years, and to me, I consider this an internal brace. That's how I've always conceptualized it. That's how I see it. And what's interesting is that I'm not the only one. What's interesting about this is that I remember back in 2013 when I met Mahada and started talking about SCR and created the internal brace using dermal allograft. Teru came out to Sacramento in 2014 to watch me do stuff and to see how I was doing it. What was interesting is that he then told me, well, you know, I use this actually just to help my rotator cuff repairs. I'm like, don't say that. People aren't ready for that yet. But ironically, that's exactly the right idea. And realistically, SCR truly was a biologic internal brace. That's really the concept. And that's kind of where we started taking this. And I'm not the only one. Teru has been doing it for a long time. I've been doing it for a long time. Ken Cutbush in Australia. And there's several other authors that have really started taking this idea of superior capsular reconstruction, not just for irreparable rotator cuff tears, but also to help with the repair of rotator cuff pathology. So, just presenting you this patient that I just showed you, the 68-year-old male with cuff pain, shoulder pain for 10 years, previous decompressions, pseudo-paralysis, and of course diminished AH distance. And when I got in there, of course, you saw exactly what you're going to see. You saw a very large rotator cuff tear that was retracted. You see a little bit of atrophy degeneration within the infraspinatus. Not a huge amount, but a little bit. So obviously we were thinking about doing SCR. And of course you see this, you get in there and you're like, okay, well, it comes over. In the old days, you would have maybe done a slide. You would have maybe, done a single row repair, but once we did the SCR, that humeral head came down. And now we could fully reduce that rotator cuff into position. What was going on, of course, is that humeral head was being subluxed superiorly, making it much further for that rotator cuff to come over. And realistically, had you done a repair, you might have gotten the head down, but it was going to fail because you would have had poor fixation, poor biology, and of course, you would have had a lot more tension on that repair. What the SCR does for us, as you can see already, is that SCR is going to be able to bring that head down, create an internal brace, allow the biology to occur. That's really what this was all about. So this was the construct. I basically did a basic SCR, but I preserved my medial row fixation. And so I hadn't actually brought down the SCR laterally. What I did was I simply used those same fiber tapes to go up through my rotator cuff and bring it down over my SCR, which came down very easily. You can see here in an ultrasound follow-up 1 year later, you can see the cuff tissue. You can see the dermal allograft. You can see the morphology of the tissue is different. And so it stayed intact. The rotator cuff healed. The dermal allograft stayed there as well and acted exactly as I wanted to as an internal brace, healing in position. Here you are, preoperative and postoperative x-rays showing you that the AH distance is clearly improved. And of course, our outcomes on this patient. What's interesting at this point, I've probably done a good dozen of these cases. They're not common because obviously you have to have enough tissue to work with, have to have just enough tissue to come over, but yet still needing that. This has completely changed how I conceptualize cuff repair. So this is him a year later, very happy, satisfied, full motion, and more importantly, full strength. What this tells me is that obviously, as Gordon's been saying, rotator cuff repair is necessary. We don't want to do an SCR. We don't want to try to replace it with something else that's really just a static stabilization. We want to retain that dynamic stability, which is then needing the rotator cuff. What it means is it's completely changed how I do things. If we take a look at actually the orange lines, that was the historical controls of massive rotator cuff repairs I'd done prior to 2013. You can see that with the green, those were my SCR outcomes and data. But what's more interesting is taking a look at my current outcomes of massive cuff repair as well as my massive cuff repairs with augmentation. And what you'll find is that I'm doing a better job at selecting my patients of what I should be doing. Internal bracing has helped me understand which cases should be repaired, which cases need help to be repaired, because the internal brace is going to make a big difference in the outcome. What it does for me is it helps keep that head down, it takes tension off my rotator cuff repair, and allows the biology to work. So, what does that mean? Now, obviously, doing a traditional internal brace over an SCR is of course doable. Tom Dooney and I discussed this a long time ago when we first started conceptualizing the SCR. We asked ourselves, do we need to have an internal brace? And we considered doing it. The hard part was how to tension it. At that time, we weren't exactly sure. So we proceeded on our project doing just SCR with dermal allograft. We found if you do it technically well, it works quite well. Our outcomes are very good, but it is very technically challenging. And if you don't get the technique just right, you will have a poor outcome, as we've seen on many of the current studies that don't do it so well. But we never gave up on the concept that SCR with internal brace might be very beneficial. Well, we weren't wrong. Matt Ravenscroft, just across the pond here, in fact, has been doing research on this. He's actually looked at it himself. He was forced that direction because he started noticing that some of his outcomes on SCR weren't so good. He was having some pull-out and some failures of his graft. That forced him to start looking into it. Now, he was able to actually, through anatomical considerations, find the same thing that I had. My original concept for SCR was, in fact, to use double row fixation. I used 2 anchors more laterally, and then I used a medial row anchor for double row fixation on my glenoid with my SCR. Well, he took a look at it and found the exact same situation. There's plenty of bone, just lateral to where the nerve and the artery sit. There's a small little area, a flat area just behind the behind the labrum. That area can be utilized easily for fixation. No problem. It's a very safe area, and it's easy to find as well. So, Matt, of course, started looking at corkscrews, suture tacks, fiber tacks, swivel locks, all kinds of different options. And he settled on doing this using a simple swivel lock medially with those fiber tapes over the top. You can see it holds it down very nicely. The tensioning, though, is obviously something that's very important, and you've got to get that just right, just as everyone else here in this room has learned and has talked about over and over again. The tensioning is critical. You do too much, you're going to increase joint reaction forces, have pain, problems. But it is easy to fix, as we heard Chris talk about. Just go in and cut it if you have to. And of course, if you make it too loose, well, it's not going to do anything. So what he started doing was, he was fixing his speed bridge. He was fixing his speed bridge SCR in standard, just arm at the side. And then he was using fixation for the internal brace at 30 degrees of abduction, so he had a little bit of leeway. So this is the Ravenscroft technique. Now you'll notice he takes away the labrum completely. I don't agree with that. I leave my labrum in place to help with stability of the joint. He pops in his swivel lock there onto that glenoid. As you can see, it's pretty far medial, so you can tell if you left your labrum, you'd still be safe. That's plenty of space. He goes ahead and puts those fiber tapes out of the way. He then is going to go ahead and do his SCR. And once that SCR is in place, he'll bring those fiber tapes back into play and bring it over laterally to fix it and create his tension. And I think this is a very valid way to do this. And the thing that I do like about what he's doing is that he's doing what I've always said. Make sure your measurements are correct. Make sure the graft is going to go in with the proper tension. So he's doing all the correct key steps to make sure he's going to succeed. That's when the internal brace will come into play and hold in place. What he also found was it did not restrict any kind of range of motion when input in correctly. So if you follow the simple steps, you actually get a very good outcome. And as you can see here at the very end, after he ties all this in, he'll end up being able to go grab those fiber tapes, bring them out laterally, and fix them where he wants them. One will go anterior, one will go posterior in his swivel locks, and I'll make sure that he's then able to have rotation. It will, of course, potentially restrict any kind of adduction initially, but essentially it's something that isn't going to be a big problem for these patients. And as we all know, and I'm going to talk about this tomorrow when I'm going to introduce a potential new concept about permanent fixation versus temporary fixation of your internal brace, and I'll go over that tomorrow. So they did some testing, of course, looking at internal brace, and they did two different studies. They did a standard and updated. The updated, they tested these samples for slack being built in. Like, is it okay if there's too much slack? In fact, I think you were talking about that. Like, you're really cautious about in case there was too much slack, that might be a problem. With their data, they determined that actually that was not an issue. What they found is that the variables that they looked at initially was how much tension was being loaded onto it. What was interesting after looking at all the different calculations, here's the data. What's interesting is that if you look at the internal brace with slack versus the internal brace, at a certain point, it all became essentially normalized. And so at least with the shoulder, there's enough diversity, there's enough looseness within the system that even if you built in a little bit of slack to the internal brace and then you load it, it's still going to engage. So the key, once again, with internal brace for at least the shoulder is just not to over tighten it. If you've under tightened it a little bit, it's actually still going to be of benefit and help by going ahead and keeping that shoulder in place and protecting your repair. But ultimately, I think that's going to be the key point, is that you really have to protect the repair. For example, if you look at the numbers on no augmentation, there's a large difference with internal brace with slack versus no augmentation. There's no doubt the internal brace makes a difference even if it's a little bit loose. This is the hysteresis width, same concept, same numbers practically, and then the construct stiffness, again, showing quite similar numbers as well. Obviously, the difference being internal brace with slack had a little bit less stiffness. Now, at this point, the key is the graft can stretch. That's part of the dermal allograft. That's been the complaint of the dermal allograft, that it's stretchable. But that's really not a problem. The issue is going to be more about making sure we get enough time to allow that healing to occur without that elasticity coming into play and becoming a problem and having those anchors potentially fail. And then that brings me to the last topic for rotator cuff today, which is the newest suture patch. People have been asking, well, internal bracing, does it have to be a fiber tape? Well, no. It could be a lot of different things, right? We all know that. Just fiber tape and suture tape is what we've used in the past. But realistically, I'll argue that this suture patch is the same darn thing. It's simply just an internal brace. And it's something that you can fixate medially, again laterally. This will allow you to put in a weaker graft and not have to worry so much. It'll allow for ingrowth of the tissue over it. And potentially this has potential usage in cuff repair as well. This has already been done. The first case was done about a few weeks ago in Japan by Teru Mahata. And actually at this point, I believe he's already done a couple since then. But you can still see he still uses quite the beefy graft. More than I would use. So at this time, I think internal brace is a super exciting, innovative direction. Obviously, for you guys, it's not innovative because you've been doing it for over 10 years. I likewise have been doing it over 10 years when I met Gordon in 2012, and I've been doing it for all my knee stuff. But for the shoulder, of course, we're all used to seeing like AC repair and these other things, but I think the future is bright about extending that to other applications within the shoulder as well. Thank you very much.